All right, good afternoon, everyone, and welcome to the Alliance Virtual Town Hall. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to welcome you to today's program, which will focus on a very timely topic of COVID in pediatrics. As always, before we begin, I'd like to briefly review some very important details pertaining to today's program. First and foremost, you may have noticed that your audio lines are muted. Please note that your lines will remain muted for the duration of the town hall presentation. That said, all questions or comments will need to be submitted electronically using the Zoom chat feature. For those of you who submitted questions beforehand, please know that we've done our best to compile your questions and we'll have our speaker address as many of them throughout the course of the presentation. Should you have any additional questions, please feel free to submit them using the Zoom chat feature. For those of you who may be new to Zoom, the chat feature is located in the very bottom of your screen in that navigation bar. Following the conclusion of today's town hall, you will receive an email from us with outlined instructions on how to access a post-town hall evaluation. Now, while continuing education credits are not offered for this program, you will have the opportunity to claim a certificate of completion as a result of your participation today. We highly recommend that you complete these evaluations as your feedback is invaluable to us and will help us develop future programs. If you have any issues, please don't hesitate to contact a member from the Alliance team. As an added note, we will be recording today's presentation. So if you or a colleague is interested in viewing today's town hall at a later date, you can access the recording on our website at organdonationalliance.org. There, you'll also find information about our upcoming programs, including details about our very next town hall, which will focus on the key elements for honoring donor designation in DCD cases. We invite you to join us for that on October 6th at 2 p.m. Eastern. Now, with all that said, I'd like to go ahead and begin today's town hall by introducing our moderator, Candy Wells, Director of Organ Utilization at Life Center Northwest. Candy, it's a pleasure to have you with us today again. And at this point, I'll go ahead and turn it over to you to begin today's discussion.
Great, thank you so much. And I have the great pleasure to introduce Dr. Nakagawa. So I'll start by doing a little bio and then he'll begin his great presentation that I know we're all really excited to experience. So Dr. Nakagawa is a pediatric critical care specialist. He's the professor of pediatrics at the University of Florida College of Medicine and the medical director of the Pediatric Intensive Care Unit at Wolfson's Children's Hospital in Jackson, Florida. He continues to serve as the assistant medical director for Carolina Donor Services in Durham, North Carolina. Dr. Nakagawa is actively involved in issues pertaining to end-of-life care, organ and tissue donation, neurologic and circulatory determination of death, and ethical issues. He has served on national committees including Secretary of Health and Human Services, Advisory Committee on Organ Transplantation, and the UNOS OBTN Pediatric Transplant Committee. He was national faculty and co-chair for the Organ Donation and Transplantation Collaboratives sponsored by HRSA, and co-chaired 3 national pediatric organ donation summits in the US. Dr. Nakagawa also co-chaired the Organ Donation and Transplantation Alliance Donor Management Task Force Committee. He continues to serve on the board of directors for the Organ Donation and Transplantation Alliance as the representative for the Society of Critical Care Medicine. Dr. Nakagawa is nationally and internationally serves as a consultant for issues pertaining to pediatric organ donation and tissue donation, the determination of circulatory and neurological death. Dr. Nakagawa was a consultant for the American Academy of Pediatrics for the revision of the Pediatric Organ Donation and Transplantation Policy Statement. His international work includes involvement with expert panels on the Canadian Council of Donation and Transplantation, the Geneva Conference on Pediatric Donation, and the Canadian Pediatric DCD Initiative. Dr. Nakagawa also has authored numerous articles and book chapters, including Pediatric Donor Management and Dosing Guidelines utilized by OPOs nationally. He's the lead author of updated guidelines for the determination of death in infants and children from the Society of Critical Care Medicine Academy, American Academy of Pediatrics, and the Child Neurology Society. He's provided expert reviews for critical care medicine, pediatric critical care medicine, intensive care medicine, chest, Transplantation, and other medical journals. He is actively involved with the Society of Critical Care Medicine, whereas he's held leadership positions, including chair of the pediatric section on the steering committee, and he also currently serves as the pediatric representative on the SCCM Council. Dr. Nakagawa is well renowned nationally and internationally as a speaker and has lectured extensively, providing more than 275 lectures in 14 countries. He has been recognized regionally and nationally for his leadership and involvement with ethical issues, end-of-life care, donation and transplantation, determination of death, and his work in the field of pediatric medicine. And again, I am very privileged to be involved today, and I will pass it over to you, Dr. Nakagawa, to proceed on with the presentation today on kids and COVID.
Great. Candy, thank you. And to everybody, welcome. I want to take this time to thank the Alliance for inviting me to get this first slide up here. For inviting me to speak today about kids and COVID. So we're going to spend the next 25 minutes or so basically talking about a lot of different aspects of children and how this disease, COVID-19, is affecting children. As I get started here. My disclosures. I will state that the information that I am presenting today is the most recent information that I have regarding COVID. And the information about COVID is really emerging at a very rapid pace. And it changes from day to day. So my presentation today is really based on the latest facts that I have over the course of the last several days. And actually some of this may have changed between now and then. So this presentation doesn't necessarily reflect future changes to diagnosis, management, and treatment. The objectives of today's talk are to review. Can you see video okay? Okay. Or to review the effects of COVID and children. We're going to talk about the spectrum of disease, including the long-term consequences of COVID-19 in children. And then we're going to review the effects of COVID-19 on pediatric donation and transplantation. Now, let's see here. Technical difficulties here. Now, I reside in the state of Florida, and Florida is home to the Kennedy Space Center. It's also home to hurricanes. It's home to key lime pie, alligators, and a lot of bad ideas, and some fun stuff like Disney World. And importantly, it's one of several states currently with the highest number of recent COVID cases in the US. We are well aware of the SARS coronavirus 2 virus that has emerged from Wuhan, China in late 2019. And SARS coronavirus 2 is the virus that causes COVID. As of September 14th of this year, US infections actually numbered more than 6.5 million, and deaths related to COVID were approaching 195,000 since the pandemic started. Cases are currently on the rise in North and South Dakota, Missouri, and Iowa, and we still continue to see a number of cases in Florida, Texas, Arizona, and California. We do know that no vaccine currently exists for this virus, and we continue to learn more about this virus every day that continues to infect people and leave some of us with long-term effects from this virus. Now, I'm going to give you a little background on the virus, transmission and infection, and then we'll move away from a lot of the medical, molecular, microbiological stuff here, but the SARS-CoV-2 virus belongs to the coronavirus family, and it's a single-stranded RNA virus similar to the SARS-CoV-1 virus that was associated with the severe acute respiratory syndrome, or SARS, outbreak that occurred in 2003. The coronavirus can infect humans and a variety of animals and birds, and the SARS coronavirus 2 is thought to originate from bats. The large family of coronaviruses causes a whole spectrum of disease, from common cold, gastrointestinal symptoms, to very severe illness where death can actually occur. It's transmitted primarily by respiratory droplets after coughing or sneezing. It can be transmitted from animals to humans, although the typical vector of transmission is human to human. And humans, we do know, can infect animals as well. The SARS coronavirus 2 has this big spike protein, and the spike protein is this thing that you can see right here on the coronavirus, and it's called coronavirus because it looks like a big crown. And that spike protein binds to the angiotensin converting enzyme 2 receptor. That's the ACE2 receptor, and it's widely expressed in the respiratory endothelium. And this is how the virus typically enters into the body through the respiratory tract. Now, importantly, the ACE2 receptor is present in most organs, and it accounts for the very wide spectrum of signs and symptoms that we see with a virus, because you have ACE2 receptors in the brain, the heart, liver, kidney, lung, stomach, small intestines, the colon, the skin, the lymph nodes, bone marrow, the spleen. And importantly, the ACE2 inhibitor is actually seen in lymphocytes. And this accounts for the low lymphocyte count that we typically see with patients who have COVID-19 infections. Now, once this virus enters into the cell, the virus replicates and eventually causes cell death. The other thing that we've learned about the SARS coronavirus 2 is that it directly affects and activates endothelial cells, very similar to what we see in sepsis. And this viral effect on the vascular endothelium, causing a endotheliopathy, actually can result in a significant coagulopathy in these patients. Now, the signs and symptoms for most people are mild: fever, cough, sore throat, just like any other virus. You can have malaise, myalgias. But the respiratory symptoms can vary. They can be very mild, but they can also progress very rapidly to respiratory difficulty, shortness of breath, fulminant respiratory failure, even pneumonia. Headache, cognitive changes, diarrhea, vomiting, ageusia, which is loss of taste, and anosmia is loss of smell, is a common finding with this virus as well. Mucocutaneous involvement can occur, and that typically occurs in the form of a rash. And as I've already stated, we can see coagulation disturbances with the SARS coronavirus 2. Now, the virus itself can cause mild disease, and it can result in severe life-threatening disease with significant lung disease manifested by the acute respiratory distress syndrome, ARDS, and cardiovascular collapse. And this can occur very, very rapidly, especially in adults. The SARS coronavirus 2 can lead to a significant inflammatory response, and that inflammatory response results in the release of a significant amount of inflammatory mediators that result in what we call a cytokine storm. And this is the result from overactivation of the immune system. Now, this rapid progression actually can lead to life-threatening complications, including cardiorespiratory failure, multi-system organ failure, and also death. Now, let's talk about kids. Can kids get COVID? The answer to that is yes. Do they get as sick as adults? The answer to that is not necessarily so, but although they can have a milder clinical course of COVID, they still can get very sick. Now, it shouldn't be surprising that diseases in children don't cause significant or are less severe than in adults. I mean, we see this with other illnesses in childhood, such as chickenpox. Kids get chickenpox, but it can be life-threatening in an adult. The next question is, can kids spread COVID? And the answer to that is yes. Okay, because if kids can get COVID, then kids can actually spread the SARS coronavirus 2. and that just makes sense. Well, do we really know that? Well, let's look at this from just a basic logical standpoint. Kids are germ factories, and although they may not get as sick as adults, they can definitely get sick. And if we think about this, if kids can get sick from the SARS coronavirus 2, and if they get sick, they can spread the disease to others. Do we know this is a fact? Absolutely. I mean, think about this. If you're a parent and you put your kid into daycare, what happens? By the end of the first week in daycare, your child's sick, and so is everyone else at home. So the child gets the disease, and then you end up getting the disease because they pass it on to you. Kids can spread disease to other people, and this is important because adults do get sicker than kids, and we know there are a certain population of patients that are more vulnerable to the disease, such as those the elderly, patients with comorbidities such as obesity, hypertension, patients with chronic disease, lung disease, heart disease. Any of those can result in putting a patient, an adult, at higher risk. Now, just this week, the CDC came out with transmission dynamics of COVID-19. And we already know that older children, adolescents, can transmit the disease in school settings. We're seeing this in schools. We're also seeing this in colleges. But they just announced that infections amongst young children acquired in childcare settings were transmitted to household members. And I think this is important because it just reinforces the fact that anybody can transmit or spread this disease. Now, the important thing from this particular CDC transmission dynamics release earlier this week is that transmission was observed from 2 of 3 children who were confirmed COVID-19 positive, but they were asymptomatic. And that's important because a lot of kids are asymptomatic and they can spread the disease. Now, if we look at data from the American Academy of Pediatrics earlier this month, we can see that over 500,000 children have contracted COVID-19 and have been, they represent about almost 10% of all COVID cases in the United States. The deaths related to COVID, though, remain very low, about 0.3% of all COVID-19 deaths. Now, if you look at the graph on the bottom there, we can see the cases, hospitalization, and deaths all have continued to rise since early May. Global data on the spread of coronavirus shows that children and young people make up only about 1 to 2% of all COVID cases worldwide. And the vast majority of the reported infections in children are mild or asymptomatic, and there have been few recorded deaths. The rate of hospitalization among children is about 8 per 100,000 compared to adults where it's about 164 per 100,000. And the pediatric population that are admitted show that about 20% of them were under the age of 2, and the rate of hospitalization for kids under the age of 2 is about 3 times higher than it is for kids that are over the age of 2. A third of the kids that were hospitalized ended up in the intensive care unit, but only 6% required ventilator support. There is a higher incidence of hospitalizations and also deaths in Hispanics, Latino, and Blacks compared to the white population. This is true for not only children, but also for adults. Now, it's fortunate that deaths in children are few, but as of yesterday, the CDC released pediatric data on deaths from February to July. And in that particular release, 75% of the children who died had underlying medical conditions such as asthma, obesity, neurologic and developmental conditions, and cardiac conditions. And nearly half had 2 or more underlying conditions. So there are comorbidities associated with children, just like adults. 25% were previously healthy with no pre-existing conditions or comorbidities. And in fatal cases, again, we see a higher incidence amongst the Hispanic and Black population compared to the white population. So 45% were Hispanic, 29% were Black, 4% were American Indian or Alaska Native. The median age of death was 16, with 10% of deaths in infants, 20% in children 1 to 9 years of age. Now, we also have another dashboard that we look at, which is a virtual pediatric ICU systems database. And they have been collecting data on COVID-19, which is shown in this slide here. And this is the latest data as of yesterday, September 16th. Now, there's 185 pediatric ICUs from around the United States and Canada that provide information that feeds into this information for the dashboard. And as we can see, there have been 1,607 children who have tested positive for COVID, and there have been 54 confirmed deaths. If we look at this, we can also see that there's 369 of these MIS-C cases, and we're going to talk a little bit more about that in a few minutes in this particular talk. Now, there is a spectrum of disease that we deal with in children, just like in adults. In very mild form, children may have no symptoms at all or only very mild symptoms, but that can progress and they can get sicker. And then we have at the far end of the spectrum, this MIS-C, which is a multi-inflammatory syndrome in children. The signs and symptoms in children are very similar to what we see in adults. Fever is very common, cough, respiratory, myalgia, sore throat. Some kids can have a rash. Headache is common if the child is old enough to tell you they have a headache. GI symptoms are very common, diarrhea, vomiting, and then loss of smell and taste can also occur, providing the child's old enough to actually tell you that. Some studies from the US and other countries have reported fewer children experiencing fever, cough, and shortness of breath compared with adults. And as I've said before, most of these kids really do have a milder clinical course, though there's a small percentage of these children, especially with comorbidities, that can have severe or critical illness. The Royal College of Pediatrics and Child Health in April of this year put out guidance on this pediatric multisystem inflammatory syndrome after they started seeing cases of this. And in May of this year, the CDC put out a health alert about the multi-inflammatory syndrome in children, which we call MIS-C. And the following day, the World Health Organization put out a scientific brief on MIS-C. Now, the CDC health alert defined criteria for MIS-C. And this was basically any individual less than 21 years of age who presents with fever, laboratory evidence of inflammation, and evidence of really clinically severe illness requiring hospitalization with multi-system organ involvement. And multi-system was defined as greater than 2 organ systems involved, which could include cardiac, renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurologic. And importantly, there was no other alternative diagnosis. So these kids weren't septic. They didn't have bacteremia. They didn't have another cause for the fever and the multi-system organ involvement. And the third criteria was they had to be positive for current or recent SARS coronavirus 2 infection by PCR testing or antigen testing, or they had to be exposed to someone within the 4 weeks prior to onset of the symptoms. Now, there were 2 studies that were published earlier this year about the multi-inflammatory syndrome in children, and both these were in the New England Journal of Medicine. And you can see the 2 graphs here, and we'll start with this first graph here. The blue cases are the number of children with COVID infection, and then in the red we see the MIS-C cases. And in this graph here, the orange are the number of kids with a COVID-19 infection, and the red are the MIS-C. And what we see is that MIS-C typically follows a COVID infection 3 to 4 weeks later. And this has led many to believe that MIS-C is really a post-infectious complication of the COVID infection. And in fact, many of these kids that are COVID positive were actually asymptomatic. So when these kids are coming into the hospital, we're testing them for COVID. We're also testing them for COVID antibodies to determine if there was a previous infection that was present. The MIS-C data from the CDC was released, and this is as of September 14th that we collected. You can see that they've reported 792 confirmed cases of MIS-C with 16 deaths in 42 states. Now, the average age of the MIS-C patient is 8 years. of age, with the disease spanning kids ranging from 1 to 20 years of age. There is a higher incidence in the Hispanic and Black population. Almost all cases tested positive for the SARS coronavirus 2. And those that were negative actually had been exposed to somebody who was COVID-19 positive. Now, importantly, we're not just seeing this in children, we're also seeing this in young adults. And there's a high incidence of this hyperinflammation and cardiac involvement that we're actually seeing in these young adults that also have comorbidities as well. We look at the symptoms. Persistent fever for greater than 24 to 48 hours is present in all the MIS-C patients. Abdominal pain and diarrhea, vomiting are in fact very common in this disease process. And in fact, the abdominal pain can be so severe that some of these children have actually had exploratory laparotomies performed to rule out appendicitis. Mucocutaneous involvement in the form of a rash can occur, conjunctivitis, cracked lips, neurologic symptoms such as headache, lethargy. They can be encephalopathic. You can have swelling of the hands and feet. And many of these kids will have respiratory symptoms such as shortness of breath and fatigue, although this is less common in the MIS-C population of children than, for instance, in adults. Now, the respiratory symptoms that we see many times are a manifestation of the decreased cardiac function that we see in this patient population. And so their work of breathing is really designed to try and help maintain oxygenation and cardiac output. Cardiorespiratory support is commonly required for these kids, and they can get sick pretty quickly. Some can develop significant decreased cardiac function. They have elevation in their cardiac enzymes and really manifest as a myocarditis. Many of these kids also require vasoactive agents for short periods of time. Some of these kids can actually develop coronary artery aneurysms, and they do require close monitoring and treatment along with anticoagulation. And this is similar to what we see in another disease in children called Kawasaki disease. And it was initially thought that MIS-C and Kawasaki disease were very similar. In fact, they're two different entities, although they share similar symptomatology. In all these kids, there's a hyperinflammation state that is present. And so we see a massive increase in inflammatory markers in the body. And we treat these patients, these kids, with immune globulin, corticosteroids. And if they are refractory to that treatment, we'll add in biologics that will help suppress the inflammatory response by affecting some of these immune mediators. Now, it's interesting because as I've had lots of conversations with my colleagues in New York where COVID cases have decreased, with the decreasing COVID cases, they're not seeing MIS-C. In Florida, we have a high number of COVID-19 cases, and Texas is seeing the same, Arizona and California are seeing the same. And here in Jacksonville, we see several cases of COVID and probably 1 to 2 cases that look like MIS-C or are confirmed MIS-C on a weekly basis. I'm going to shift gears now and talk about the impact of donation and transplantation. And this is the second part of this talk. Our data from UNOS shows that transplants and deceased donors to date are relatively equal to what we saw in 2019. The difference here is living donor transplants, which have decreased. And is that really concerning? And the answer to that is, I don't think it is, because this should have been expected with reduced hospital visits, isolation during the pandemic, and concerns about disease spread. In many institutions across the United States, elective surgeries were put on hold, and there were actually some programs of suspended living donations. So that's not unusual to see that. But to date, it looks like the number of deceased donors and the number of transplants we're doing are on par for what we saw in 2019. Now, if we look specifically at the COVID data and pediatric donation and transplantation rates, you can see the 2019 donor and then 2020 donors here. And again, our donor information for 2020 really carries us through July 31st, so half of the year. And if we look at transplants, the same thing, half a year statistics for 2020. But essentially, we're on par with 2019 data. So overall, it doesn't seem like COVID has affected overall donation and transplantation rates in children or adults. Now, it's not to say that some areas of the country haven't been hit harder than others, but if we look at the overall data, it seems like the number of donors and the number of transplants we're doing is pretty much on par with 2019 data. Many of you have heard me speak before on donation as a process, and it's really no different in the COVID era. The recovery of organ from children always requires good communication and collaboration with the OPO and the ICU staff. And this is whether you're dealing with adults or children. It's especially true when we're dealing with any infectious disease issues in children, and more so with COVID. The American Society of Transplantation and the Canadian Blood Services have provided recommendations and guidelines for organ donor testing and guidance on organ donation and transplantation during the COVID-19 pandemic. And I'm going to share with you some of those testing recommendations and recommendations for donors who are positive for COVID. The AST is rightfully so to remind us that no test is 100% sensitive or specific, and we can have false positives and false negatives that can occur. And just like any other patient, the risk-benefit ratio for an individual who is a transplant candidate always has to be taken into consideration when making that final decision to perform a transplant. So this includes the risk of proceeding with a transplant as well as the risk of actually deferring or potentially foregoing the transplant. Recommendations for donors who are positive for COVID-19. Well, the first thing is they should be tested again, and they should test negative for COVID based upon nuclear antigen testing assays. If they're still positive, COVID positive donors aren't going to be, or COVID positive patients aren't going to be donors. It's important that we look at this, because if they've had the disease and they test negative, the question is, can they be a donor? And the answer to that is they might be able to. What we don't know are really the long-term consequences for kidney, lung, and other organs that might be transplanted if they have been exposed or the patient's been infected with the SARS coronavirus 2. So the long-term implications are really unclear. And data regarding the safety of organ donation from donors with previous COVID infections are extremely limited at this time. Next question is, can a transplant recipient get COVID from a donor? And the risk of getting the SARS coronavirus 2 from an organ donor is really unknown. Now, all OPOs screen their patients. We do exposure history for all those potential donors out there. But again, it's recommended that if a donor is COVID-19 positive, they're not eligible for donation. Transplant recipients, on the other hand, really need to take appropriate precaution and self-isolate so they don't become infected. And this is really important, because if they do become infected and they're transplanted and they're immunosuppressed, we have no idea what might happen to that transplant recipient. Now, again, to reiterate, the recovery of organs, not only from children, but from also adults, requires good communication and collaboration between the OPO and the ICU staff. What about post-transplantation risk? Well, it's really unknown whether solid organ transplant recipients are at higher risk for acquiring the SARS coronavirus 2 infection than the general population. Now, to date, no organ donor-derived infections have been reported. It's hypothesized that chronic immunosuppression can lower the infectious dose needed to cause COVID-19 because the immune system has been suppressed. But the flip side to that is that we are actually treating active COVID infections, and we're treating MIS-C in children with steroids. And this is different because other viruses we wouldn't treat with steroids, but that's one of our first line treatments for these kids and for adults as well. Now, organ transplant recipients could also have frequent contact with the healthcare system, and it's hypothesized that they may be potentially more likely to be exposed to the virus. The flip side to that is in the healthcare community, in the hospital, healthcare provider infection in hospitals has been extremely low because of PPE, and we take appropriate precautions to isolate patients and isolation during procedures. And so like any other immunosuppressed person, we also have to think about this because they may not be able to clear that virus and they may hold on to the virus longer. Do we know that for a fact? We don't know that for a fact. So this is all really hypothetical. So are they at increased risk? Potentially, just like they would be anybody else who's immunosuppressed. But again, if we're using steroids, that's our first line treatment for COVID or MIS-C. What are some of the long-term considerations regarding COVID-19? Well, the long-term medical consequences from the SARS coronavirus 2 are really unknown. How it affects long-term the brain, the heart, the lungs, and other organ systems is really unknown. We do know that the patients do have persistent lung injury, and it does get better over time. It is unclear if immunity develops following the contraction of this virus. And if you do get immunity, the question is how long does that immunity last? There are some known and anticipated consequences that we have to think about. And the first one of those is vaccinations. Because of COVID, because health visits are down, children are missing scheduled physician appointments, and immunizations actually may be delayed. And we worry about this in pediatrics because these kids, as we move into flu season, if they haven't had their full immunization series, may be at risk for a resurgence of other childhood diseases such as tetanus, diphtheria, mumps, measles. SARS coronavirus 2 vaccine is entering clinical trials, but the safety and efficacy are really unknown. And this becomes really important because we have to make sure that this vaccine is safe and effective. If we roll out a vaccine too soon and there are side effects or significant safety issues, this could be devastating for the medical community. And I say that because it potentially gives more ammunition to anti-vaxxers to defend their stance and their campaign that vaccinations do more harm than good. It's also important to remember and keep in mind that some vaccinations prevent disease. Vaccinations like varicella or Haemophilus influenza B, tetanus, diphtheria, measles, the human papillomavirus. And then there are other viruses like the flu virus that may confer some immunity, but you can still get sick, but with lesser symptoms. And again, we have to remember that viruses mutate and that can affect the host response to the disease as well. And finally, we have to think about distribution and allocation. So when the vaccine becomes available, who gets the vaccine first? Is it going to be mandatory for healthcare providers? Are the elderly next in line? Is it going to be kids? And how are we going to allocate this, especially if the safety profile hasn't been completely proven? I'm going to close out here with a few more slides. A big question for some of you who are parents out there, should I send my kid back to school? And that's a big question that many of you have. School is important. The American Academy of Pediatrics has actually issued statements on this. It's important for socialization as well as education. But sending your kid back to school really depends on many factors. First, you need to consider what the prevalence of disease is in your state and in your community. You also have to think about whether or not you have contact with elderly family members or members who may be immunocompromised or at higher risk to contract COVID. And importantly, do you at home, you and your family members have comorbidities that put you at risk for more severe disease? Because this isn't just a disease that affects only the elderly or the young. We're actually seeing more and more young adults contracting the disease, and it's resulting in significant medical issues and prolonged hospitalization from complications related to COVID. So we go back to the basic fact that we know that children can spread the disease, and there are increased positive testing for viruses as colleges have reopened and more cases are occurring in places where there have been large gatherings, indoors and outdoors. And so I think it's important that you take all those things into consideration when you're thinking about sending your child back to school. Last thing I'm going to close out with is prevention. And I think prevention is important, and I can't just end this without mentioning this because as healthcare providers, I think this is everyone's responsibility, especially us, but also everyone in the community. And it's amazing that 100 years later, the same precautions that helped to end the Spanish flu pandemic are actually being utilized to curb the spread of the SARS coronavirus too. And that's basically simple things like wearing a mask, washing our hands, avoid touching our face. Is wearing a mask really that important? Well, I think it is. Everyone's going to have their opinions, but remember, the mask can protect you, but it's really designed to protect others. Now, I'm going to put this in perspective. Why do you think a surgeon wears a mask when they're operating, or why do I wear a mask when I'm doing a procedure? I don't think any one of us would accept a surgeon operating on us without a mask. The mask isn't there to protect the surgeon, it's there to protect the patient. And the same is true of all of us that work in the transplantation industry. If we have an immunocompromised transplant patient, what do we do in the hospital? We put a mask on, we wash our hands, we put on a gown, and then we go and see the patient. Why do we do that? Because we're protecting the patient. So this is really important. And in fact, in a recent presentation to the Society of Critical Care Medicine this past weekend, Dr. Fauci said that 40 to 45% of all infections are asymptomatic, stressing the importance of universal masking. And in fact, today, the Centers for Disease Control just came out with another health alert. Over 50% of pregnant females who delivered were asymptomatic and COVID positive. So what can we do? Well, wear a mask, wash your hands, maintain your social distance, limit exposure to large crowds, indoor events or restaurants that pose a high-risk environment to spread or catch the disease. If you have to go out, take the appropriate precautions. Be responsible. Stay at home and quarantine if you're sick so you don't expose others. I will say that for the number of years that I've been involved with the donation transplantation community, we have always looked out for one another, and we've always looked out for patients and families, and we understand the need to protect and advocate for one another. And we understand that donation is more than just about us. It's about the patients and the families that we serve. And during the COVID-19 pandemic, this is really no difference. So in closing, I do want to say thank you to all of you for allowing me to spend a little time with you today to hear a little bit about kids and COVID. I know I've covered a lot of information, but I hope I've presented you with some useful information that will be beneficial to you as a healthcare provider and a parent. And just remember that, we're all in this together and we all need to work together. I think that's the most important thing that I can leave with you. Be kind, be caring, be safe, be understanding, and we will all get through this some way, one way or another. I do look forward to the day when we can actually once again meet in person versus over Zoom or some of these other video platforms. But I have to say it is actually very nice to be able to mute everyone all at once. So with that, I'm going to close, and I want to say thank you for allowing me to speak with you today. I'm going to take questions. I think Candy has been polling the audience out there. So thank you very much for your time, and I hope all of you are safe and well.
Great presentation, Dr. Nakagawa. Thank you so much. If you have any questions, please submit them. In the meantime, I have one quick question. As the pandemic continues to evolve, you addressed looking at potential donors that have either been suspected to have had or confirmed COVID and are now negative. As we move forward, do you think there'll be considerations in looking at those individuals as organ donors depending on their clinical course with COVID? So if they were asymptomatic, but positive compared to someone that may have been hospitalized and ventilated and had additional challenges, do you think that will impact our ability to move forward in some of those cases?
That's a good question. I do think it will impact that. The asymptomatic patients may test positive, and we don't know how long they shed the virus. I think the bigger concern that surgeons will have is what are the long-term impacts of that virus on the organ that they're transplanting. And I don't think anybody has the information to look at that currently. I think that if we are potentially dealing with a healthy individual that doesn't have a lot of comorbidities, they are probably more likely to be considered a candidate because those comorbidities obviously affect organ function right now, even if you didn't have COVID. So I think that there's a number of different factors, but I think that the patient who was COVID positive, was asymptomatic, and is now tested negative could potentially be, but I can't make that determination. That's really a surgical determination. And that's the risk benefit that has to be weighed between the surgeon and the transplant recipient.
Great, thank you. We have a few thank yous, and then Lori Markham said, you are a true gift to our industry. Thank you for sharing your time and, more importantly, your expertise. I learned something from every time I hear you speak, no matter the topic, and I completely agree with Lori. Another comment is, I'm a living donor kidney transplant coordinator from UCLA. One of our ID specialists gave a talk including patients who have recovered from COVID-19 and are they at a higher risk for future blood clots? Have you seen this?
So all of the COVID patients are at risk for blood clots. And what we do know, as I stated early in the presentation, is that the SARS coronavirus 2 affects the vascular endothelium. And when it affects the vascular endothelium, it affects the hematologic system in the bloodstream, it does potentially make you more prothrombotic. And so all of these patients now are, at least when they're entering into the hospital, are being treated prophylactically for potential blood clots. If they have a documented blood clot, then they are actually put on a therapeutic dose of an anticoagulant. So they're all anticoagulated, and that becomes very important. Is there a risk when they go home? The answer to that is there probably is, but I don't think we have all the information on that. A lot of these patients are being discharged home on an anticoagulant, and they may be continued for 4 to 6 weeks before they stop that. Again, there's so much new information that's actually emerging on all various aspects of this particular disease that the anticoagulation has to be weighed into the other comorbidities that patient has. For instance, if you have a patient that presented with neurologic obtundation and they have a stroke and they're COVID positive, you probably are not going to anticoagulate them if they were a hemorrhagic stroke. So there's a lot of different variables that have to be taken into account for that. For the healthy individual with minimal comorbidities, they're probably going to be discharged home on anticoagulant therapy for potentially 4 to 6 weeks.
Great. It looks like there's one more question, and then I'll ask Deanna if we have time, or shall we close after this last question? The question is, are transplant centers seeing an increase in candidates who are being considered for listing? So for listing for a potential organ transplant solely because of complications from the COVID-19 virus?
That's a very good question. I'm not sure that I can answer that. I will tell you that there have been several cases in the literature already about significant lung disease in adults where they have developed basically intractable respiratory failure and they have received lung transplants. So that is definitely occurring. Heart transplants had decreased at one point, are back on the rise. I believe there was a study out of Europe, France, maybe, I can't remember, but they talked about that decrease in the number of heart transplants. But I think that that's rebounded as well. So yes, I think that some people are being listed because of this, specifically in the realm of lung disease. One of the things that we did note in many of the adults early in the COVID pandemic is a lot of these patients, in addition to the respiratory failure, the hemodynamic complications that they were having. They also required renal replacement therapy. So there was a high incidence of these patients who had significant acute kidney injury, AKI, and required CRRT for support as well.
Great, thank you. I'm not seeing any additional questions. Deanna, would you like to close us out, or is there anything else you'd like to say before we conclude the webinar?
No, I think I just want to, on behalf of the Alliance, I want to extend a sincere thanks to Dr. Nakagawa for such a fantastic presentation. It's always a pleasure to have you with us, and I certainly echo Lori's sentiments. I think you're a wealth of knowledge, and we appreciate your ongoing willingness to partner with us and share your insights with the community at large. So thank you as always for joining us, and Candy, thank you for doing a phenomenal job at facilitating today's discussion and helping us coordinate some of the details here. So a huge thanks to you both, and to our participants, we thank you for your participation, and we hope you found today's presentation to be valuable, and we look forward to seeing you on a future town hall. Thank you, everyone. Enjoy the rest of your day.
Thank you.